Mr. Florentine, did you see the TED Talk for tonight?
I did, yes.
Good.
I got the memo today.
Important things. I'm going to wait for a minute, see if Christina comes in and stop. Well, I want to welcome everybody. It's a great honor and privilege to introduce Dr. Judy Huang, who's the Vice Chair and Program Residency Program Director at Johns Hopkins. Judy finished her undergrad at Brown and went to Hopkins Medical School, then did her neurosurgical training at Hopkins, and at Columbia, sorry. No, she went to Brown undergrad, then went to Columbia Medical School, and then neurosurgery. Were you with Ben Stein? Yeah, so Ben Stein is sort of the legendary chairman of neurosurgery and sort of influenced a generation of neurosurgeons. She finished that, then went to Hopkins, and had a really meteoric rise in neurosurgery there. She's done very well. She's a full professor. She has over 100 publications. She has publications in science, so just gives you the scientific prowess behind that. She's a really good technician, and people at Columbia, you know she's very popular wherever she trains because they always talk about her. Wherever meetings I go, they always say wonderful things about her. And she's been very involved with organized neurosurgery. She's involved with the Senior Society, with the NSA, so multiple areas. She's written extensively. She's a wonderful technical neurosurgeon. And I know she's very busy, but we're very fortunate she took time out of her schedule to come down from Hopkins. So without much further ado, Dr. Judy Huang.
Thank you very much for that warm welcome. It's a great pleasure to be here. There. Okay, great. So it's thank you very much for that warm introduction and welcome. It's a great pleasure to be here. I hope that I can sort of shed some light on a topic that's very dear to my heart that I've been working on for a while, and with the support of many people, including medical students and residents and faculty at Hopkins. And it is about arteriovenous malformations and hemorrhage risk. Okay, so I have no relevant disclosures, and then I'll just start by sort of laying the groundwork for why I became interested in this. So I'm going to show a description of 3 patients that I've taken care of. And they're all similar in that they're very young, healthy women who really had no problems before they presented to me. So the first one is a 21-year-old student who had headaches, and she had this MRI, and you can see this Rolandic region AVM, and then the angiogram below, it's a Spessler-Martin grade 3 AVM. It's greater than 3 centimeters, it's eloquent, and then there's no deep venous drainage. The next one is a 25-year-old nurse who actually worked in the hospital and had a seizure while she was on break in the hospital. So of course the neurosurgery residents get called to consult because there's a significant finding on the head CT, and then we image her a little bit more. And you can see that she's got this AVM that's posterior and has a big venous dilatation. And she eventually gets a resection and does well and goes back to work and so forth. And the last one is someone that I took care of late at night. He was a 23-year-old young woman who was no past medical history and collapsed because she was at the drugstore trying to get some Tylenol for her bad headache. And she actually just totally, herniated and was comatose by the time she was brought in. And we took her to the OR for hemicraniectomy, did an intra-op angio to try to figure out the source of the hemorrhage. I actually thought she had a ruptured MCA aneurysm. I was trying to figure that out. And when we did her intra-op angio, we saw that it was an AVM. And she did not do well eventually. So these are 3 very disparate situations. But if you believe Aruba, which has sort of informed a lot of people in terms of understanding hemorrhage risk and how to take care of patients with AVMs, you'll see that this really clouds the picture in a lot of ways. And unfortunately, Aruba was published in Lancet. It is touted as a very important randomized multi-center trial that is definitive about how you treat unruptured AVMs. And you can see here that mainly their outcome, which is time to first stroke or death, is greater in interventional therapy by 3-fold compared to medical management. So if you can see the Kaplan-Meier curves here, and medical therapy is one line and interventional therapy is the other, you can see the interventional group does so much worse than medical management that this is what has made people think that you should really think twice about treating people who have an unruptured AVM. So with that background, I thought it was very important to really clarify natural history of arteriovenous malformations, because we're beginning to see this issue of, if you see a patient in clinic who has an unruptured AVM, they come to you and they expect to be told that there's no treatment necessary, that medical management is far superior than interventional treatment. And so we have to understand, this propelled me to think we have to understand hemorrhage risk a lot more, because those 3 young women that I showed in the beginning, if any, that the third one in particular, if she had come into my clinic with a small unruptured AVM, she could have been saved, right? We could have saved her life. And the other 2, they were lucky. They were able to come in without a rupture, and they were eventually able to get multidisciplinary treatment. So the first one actually got embolization, radiosurgery, and then surgical resection. And the second one was just resected. So both of those women are doing fine, and in contrast, the third one is not so lucky. So I thought it was important to really hone in on this natural history question a little bit more. So I'll just give you, this is the quick intro that everybody knows about. They learn about this in medical school, about what's the incidence of AVMs. It's actually a very rare disease. It only represents 1.4% of patients who are diagnosed with a hemorrhage. It does affect mostly younger people before age 40. However, presentation with hemorrhage is by far the most common presentation. A lot of these times they're ICHs, but of course you can see subarachnoid hemorrhage and also IVH. Seizures, headaches, and focal neurologic deficits are really much less common. So in terms of what has been published in the past, we know that the overall risk of the initial hemorrhage is approximately 2 to 3% per year. However, the mortality from the first hemorrhage is 10 to 30% per year. And then the survivors with long-term disability is much higher, 10 to 20%. The quick and easy way to calculate the lifetime risk of hemorrhage is to subtract their age from 105. And this is a list here of all the previously published cases that really number in the hundreds in terms of patients. And this comprises the retrospective series that are used for these natural history statistics. So we also know that if you have one hemorrhage, your risk of a recurrent hemorrhage is actually much higher. So that in the first year after the initial bleed, you really have a great increase in the repeat hemorrhage rate of 6 to 18%. And then it can be as high as 25% if you have 2 hemorrhages. So the more you bleed, the more you bleed. So these are the known predictors of hemorrhage that have been well described in the literature. That includes prior hemorrhage, seizures, actually small AVM size, and then there's different anatomical features that have been characterized as predictive of hemorrhage. And these include things like deep or single or impaired venous drainage, the fact that you have intranidal aneurysms or multiple aneurysms, and then periventricular or intraventricular location, as well as arterial supply from perforators, vertebrobasilar supply, and also basal ganglia location. So these are all well described. I'd like to use the rest of my talk to go through additional factors that influence hemorrhage risk. And here's the outline of the different topics that I'll cover. And a lot of these were questions that I had in the course of my practice taking care of patients who presented with unruptured AVMs, and then in some cases some ruptured AVMs. So I'll go through how age influences risk of bleed, how race, how location, anatomic features, and then associated conditions such as pregnancy or HHT. HHT was of a particular interest because I found myself being flooded by patients who would be very, very nervous in my clinic with these tiny micro-AVMs because there is an HHT center that happens to be at Hopkins. So they would get screened and there would be hundreds of patients would get diagnosed with these tiny little AVMs and they'd be all nervous. And so I said, I have to look at this because I want to be able to tell these people that with the micro-AVM, it's a totally different issue compared to sporadic AVMs. So these are the things that sort of came my way and led me to try to answer these questions. And then I'll talk a little bit about treatment modality and how that influences the risk of hemorrhage. So we'll go in order. And the way I try to address these questions is by looking at the total experience at Johns Hopkins of patients treated with AVMs. So I had a lot of help doing this, but we looked at basically a 25-year period of time retrospectively with patients coming in and how they were treated, whether it was with radiosurgery or with surgery. So it really represents pulling together data from various departments, even like radiation oncology, and different surgeons. And so right now we're up to 763 patients, and each patient has multiple data points with longitudinal follow-up. And then obviously with the recent patients that are in my practice, we are able to collect data prospectively. And so I'll start with age. We first looked at what's the long-term hemorrhage risk in pediatric patients. And the reason we did this is because few studies have really compared long-term hemorrhage risk after various treatment modalities. You'll typically see reports that take a look at a population of people that have been treated with one modality, like radiosurgery, or one modality like observation, not so much observation, but really break it down by treatment modality as opposed to comparing across treatment modality. And the reason we were able to compare across treatment modality is because we do have a larger number of patients in this database. So we actually are able to get subgroups that are substantial in size. And so with this, we looked at, you can see here, the various treatment modalities that were employed, basically surgery with or without embolization, radiosurgery with or without embolization. Some people only got embolization only. There were, and then there was a cohort that was only observed. And you can see the Spetzler-Martin breakdown and so forth. So we found, after following these patients for average of 10 years, that the rupture risk, bleed risk, was actually only about 1% per patient per year. So in the pediatric group, this is actually much smaller than what we consider as a general rupture risk. We also found that the ruptured presentation was the only factor that was associated with long-term hemorrhage risk. And then compared to other treatment strategies, surgery really remains the optimal modality for controlling this hemorrhage risk. And this is broken down here in tabular form. I won't dwell on that. So our main finding was that in pediatric patients, the natural history of hemorrhage is actually relatively low at 0.9%, and that surgical resection remains the optimal management. And so therefore, even with this low risk, AVM obliteration with surgery, especially with the patients with ruptured presentation, is essential and a valid treatment goal. So then, in contrast to the pediatric group, what about people over the age of 60? I think the residents showed me a case today of a patient who was 62 who had a ruptured AVM. So, what about these patients who are felt to be unusual because they present much later in life? It actually only accounts for 2 to 6% of all AVMs are in this population. And a lot of times, if someone is discovered incidentally to have an unruptured AVM and they're past the age of 60, really conservative therapy is what is recommended for them, because the thought is that they're a different population of people because they haven't presented earlier in life. And so we wanted to ask, is this 2 to 4% annual hemorrhage risk applicable to this group, or is this population who haven't presented earlier, or do they have a more indolent course? So we found a group of people who were over 60. I first tried to do the Medicare population of over 65, but there were fewer patients in that group, so that's why we did 60. And then the presenting symptom, actually in 44% of these were actually hemorrhage. So it actually does happen quite a bit. And we found that the mean size was 2.1 centimeters, and 2/3 of them were actually low grade in terms of Spetzler-Martin grading. Then by comparing what the management was across these, we did see that the majority, half of them, were treated just with observation. There was only a fifth who were treated with surgery with or without embolization. A quarter of them were treated with radiosurgery, and just very few with embolization only. Our follow-up here was about 3 years or so, and we only detected 6 patients who had hemorrhage at follow-up, and you can see the breakdown here with the different treatment modalities. So you can see that really in this group that observation and for obliteration, if you compare AVM obliteration, that in the observation group and the people treated with surgery, there was a marked difference between AVM obliteration. However, this did not translate to a substantial difference in decreasing hemorrhage risk. So even though you obliterated, it was not a substantial decrease in annual hemorrhage risk. So in conclusion, for this population of patients, we thought the natural history is about 3.4% risk of annual hemorrhage, but the conservative management is still the choice for the majority of these patients who are unruptured. And if they're a good surgical candidate, surgical resection is still better, and radiosurgery is really not very good for this group. Next, we looked at race, and the reason I did this is because we noticed that previous studies of hemorrhage risk was really focused on more anatomical features, and we looked at our cohort here, and we noticed that a non-white race was actually associated with 3 times higher risk of hemorrhage presentation than people who were white. And we also noticed a couple of things about location, but this was very interesting in that it also added to the evidence that a smaller AVM is actually associated with a higher hemorrhage risk. So that was sort of ancillary finding in this cohort of patients. Next, we thought that if AVMs are in the posterior fossa, that these are associated with a much worse outcome, and because of the limited space in the posterior fossa. And we tried to really hone down on what the predictive factors of functional outcomes were in these patients. So we looked at this subset, and we noticed that particularly in the posterior fossa, 2/3 of these patients presented with hemorrhage. And you can see the breakdown of what was done for them, whether it was surgery or radiosurgery or a combination of these things. And then, of course, we included the group that was treated conservatively. And we found that the only factors that predicted good outcome were having a pre-treatment MRS that was greater than or equal to 2, having successful AVM obliteration. And we found that the ruptured presentation and location were actually not predictive of outcome. And you can see here, this is just a graphic depiction of that there. Okay. So in the posterior fossa AVMs, favorable outcome is definitely associated when they're associated with asymptomatic presentation and AVM obliteration. But conversely, having a non-hemorrhagic presentation alone does not necessarily predict good outcome following treatment. So therefore, in patients who are carefully selected to undergo treatment, even those who are asymptomatic and don't present with a hemorrhage are actually really good candidates to be considered for definitive treatment, because you can get very good results in people who have not had a hemorrhage, even if they have a posterior fossa AVM. Let me see. So then I think I'm going to skip this one. I really do. This is getting... All right. So then we started to look at anatomy and different angiographic features. And I thought that size was very important because, remember, harking back to Aruba, is that there was no breakdown, really trying to hone in on subgroups of patients with unruptured AVMs. So it was very muddled when you're comparing these people who have Spetzler-Martin grade 1 and 2 AVMs, and you're comparing them with people who have grade 3 and grade 4 AVMs, because they're really a different entity altogether and natural history-wise. So in Aruba, all the very risky AVMs were being lumped in with the people who had very low-grade AVMs. And so I thought it was important to look at size, because it's very important to know which ones you should stay away from. So giant AVMs, that's an easy target, right? It's to really try to distill down the fact that giant AVMs should be left alone. These are very rare, and we found that about 1/5 of them presented with hemorrhage, but still most of them were treated conservatively, but surprisingly about 1/3 of them actually received some sort of intervention. And even though it's a losing battle, usually if you're embolizing or doing radiosurgery, you know you're not going to get obliteration, but something is done for them anyway. So we found that in terms of the long-term outcome of people who have these giant AVMs, that the conservatively managed group had larger AVMs with more frequent involvement of the temporal lobe. We found that the conservatively managed group actually had fewer hemorrhages during follow-up than the intervention group. So that essentially the risk, if you annualize it, the risk for the conservatively managed group of hemorrhage risk was actually lower than for the people who had interventions. So overall, there was an unchanged or improved outcome in 87% of the conservative group versus 50% in the intervention group. And in the treated group, you were getting a terrible obliteration rate of only 14% achieving obliteration. So it's really not a good technical outcome at all, but you're really having a disparate difference with the conservatively managed patients compared to the intervention. And so you can see that the Kaplan-Meier curves really show no difference in hemorrhage-free survival with these giant AVMs. And in essence, if you look at the graphs between the two treatment modalities, you can see that functional outcome is actually likely to be the same or better when patients are managed conservatively. So we're able to break down and say, really this is definitive evidence that if you're faced with a patient who has a giant AVM, really you should think very hard about intervening, even if they have hemorrhage, because despite whatever you do, multi-modality treatment, you're still probably not going to end up with a better MRS than if you just left them alone. This question came up as I was noticing, just like you have a patient on service right now that has a AVM that's fed by a pica, a vessel with an aneurysm on it, right? So this was something that I noticed too, that when you had the risk of, when you're faced with a pica AVM and there was an associated aneurysm with it, it would seem much more likely for the pica aneurysm to be the source of the hemorrhage rather than the AVM. And you're seeing that right now with this patient on your service. So I decided to look at this too and noticed that if you had if you looked at ruptured AVMs, if there was a pica aneurysm associated, they were more likely to present with hemorrhage related to the aneurysm as opposed to the AVM, and therefore that should inform treatment strategy. So glad to see that you're seeing that too in your population. So this I'll talk about a little bit more. I was very interested in associated conditions such as pregnancy, because this was a very controversial topic that many patients would come to me and try to get clarity on, was if they had an unruptured AVM and they were pregnant, what should they do, right? So this is always a tough discussion. And it ranges from, should I do something about terminating my pregnancy, to, how do I not travel and stay close to an ER? All these different scenarios of how one's life changes when you have this diagnosis. And so we did a case crossover design in which we used each patient to serve as their own control in comparing risk between the exposure period and the non-exposure period. So for every woman of childbearing age, whenever they were pregnant, that was considered exposure period. And then in that same patient, when they were not pregnant, that was their non-exposure period. So we mapped out basically chronologically for every patient their exposure time and their non-exposure time. So you can see graphically that this is depicted here. So for this patient, number 3, who had 3 pregnancies and 1 abortion, that these times, these dark black lines, are the times where that's exposure. And then all the light gray time periods are times when there's non-exposure. So we did that for every patient, and we saw that there were 140 hemorrhages in non-exposure periods and only 9 during the exposure periods. And interestingly, we saw that intra-pregnancy AVM ruptures occurred a lot during the 2nd and 3rd trimester primarily, really not in the 1st trimester at all. And we saw that the annual hemorrhage risk for non-pregnant and pregnant women were actually 1.3 and 5.7% respectively. So that, and then if you looked at the denominator of patients where we use the census definition of childbearing potential, age of childbearing potential between 15 and 50 years of age, the annual risk of hemorrhage is actually 7%. So that actually means that if you're pregnant and have an AVM that's unruptured, you are actually at 4-fold increased risk of having a bleed during your pregnancy. And so that's obviously important for counseling, important for being prepared. And this is, it is very interesting because this is in direct contrast to what has been published in other large populations outside of this country, where the data from China in particular is that there is no increased risk of hemorrhage during pregnancy. But we found in this study that this was consistent with other publications that have come out of the US with more limited cohorts, but we're definitely consistent here. So I think this is important. Obviously, it is still not easy to think about what happens if you're faced with a ruptured patient when they're in their third trimester or second trimester. What do you do with the baby in terms of managing that? And there's really no good data to guide that, and I think that that's a very personalized, individualized treatment that needs to happen. But for starters, this is helpful data when you're counseling patients. So I mentioned this a little bit about the HHT. We see that there's a lot of HHT patients who have multiple micro-AVMs. And it's at first very clear, if you have multiple AVMs, shouldn't your AVM rupture risk be higher than if you just had a solitary AVM? So we tried to distill this down a little bit more, and we found that obviously this disease is very rare in general. We just happen to see a lot of them at Hopkins because of the HHT Center, which are in another discipline. So we looked at this a little carefully, and we saw that there was really a difference between HHT AVM patients and the sporadic AVM patients. We saw that these patients tend to be a lot younger, they're much less likely to present with hemorrhage, and they have much better presenting functional status, and they're pretty much always totally asymptomatic. And we also saw they're a lot smaller, typically grade 1, really often multiple, and for some reason not very likely to be in the temporal lobe for whatever reason. And so here's the breakdown in terms of their data. And we saw that in the patients who had sporadic AVMs, the annual rate of rupture was 3%, whereas patients with HHT was really just 1.3%. So the conservative management really is generally recommended to due to lesion multiplicity and the relatively low hemorrhage risk. Now, you wouldn't believe, for me to be able to say this to patients, how many people are so grateful for not needing any intervention. And so it just goes to show you, if you can really reassure someone, a lot of what we do is also, it's very important to be able to reassure someone. To be able to tell them they don't need treatment, don't need follow-up, you don't need surgery, you don't need radiosurgery. I mean, some of my most grateful patients, that's what I'm doing for them. And that always amazes me, but that's what we have to do, to really selecting patients. So the next, I'll talk about treatment modality. And we started looking at this to compare hemorrhage risk between patients who were totally left alone, just conservative management, and then people who only received embolization as a single treatment modality. And this is, we were surprised because what happened, when we started following these patients, what became very evident is that patients don't really follow your advice. So this is what this shows, okay, is that, they're on the left here, this is what was recommended to them. So, they were seen and you had a recommendation either for conservative therapy or radiosurgery or surgery and a combination of these things. And then as you follow the graph to the right, you see what the people migrate into different groups. And it's because, and this is what was amazing, is that was not a parallel migration. People just really started weaving in and out of different treatment modalities. And obviously, I can't break down why this happens, but eventually what breaks down is that the conservative group and the embolization group are very different from what was recommended in the beginning. So we looked at that to see what did it translate to in terms of outcome. And we saw that actually over 10 years, the conservatively managed group actually only had a 1% risk of rupture. And in people who had only embolization, they were actually double that practically at 1.9%. So that was a surprise. And made us realize that even in patients who you don't think are suitable for surgery or radiosurgery, you probably shouldn't touch them. So even if you initiate embolization because it's something to do, because you feel like you need to offer something, you're really not, without a definitive plan for obliteration, you're not going to get cure, and you're really not going to get any improvement in their hemorrhage risk. So it's really, for these non-operable, unruptured AVMs, it really does not help. And in fact, you actually give them an increased risk of hemorrhage in their future. And so these are the populations that really detracted from Aruba. Okay, so this is a prime example of a subgroup of patients that included in Aruba really led to this bad outcome for intervention. People who only received embolization, because the majority of many patients in Aruba, actually their intervention consisted only of embolization. So it was not surgery, it was embolization only. Okay. So what about delayed hemorrhage after treatment of AVMs? I started being interested in this also because of clinical situations that I came across. And it's nice to be able to say to patients, oh, you've been treated for your AVM, you really don't have risk of bleeding in the future. You're done, you're cured. I found that this was rarely described in the literature. And when we started looking at our patients, we actually found that there were 5% of patients who had been treated who were found to have delayed hemorrhages. And I define delayed hemorrhages as those occurring 2 to 3 years after treatment because of the latency period of radiosurgery, right? So if you can't take treatment and start counting from the time of treatment, you have to count after a latency period in order to include all these radiosurgery patients. And we found in this cohort, we actually had an interval between last treatment and delayed hemorrhage being 7.6 years, and some with the one patient having actually a bleed in a delayed fashion 24 years after their treatment. So clearly this happens and is not as rare as you might think. So I was very surprised actually that 5% of patients actually have this delayed hemorrhage. And this is just an example of a very interesting case to me where this patient had multiple radiosurgery treatments and actually had angiographically obliterated AVM, so that he would come in with these hemorrhages that you can see in these CT scans. He would come in with a bleed, we do an angiogram, and there was no AVM that could be detected angiographically, and then he'd get better, we wouldn't do anything, get better, and he'd come back a few years later, so not every time was I the one involved here, but he finally came under my watch and had this bleed here you can see, and he was managed actually conservatively for a while. I tried to just, he had very bad headaches, no focal deficit, but he had very bad headaches. And I tried to ride him out. And of course we did an angio and it wasn't there, we couldn't see anything. And finally he was so symptomatic that he was not able to work, was not able to really function because of these excruciating headaches that didn't get better after a couple of weeks. So I finally took him to surgery, and of course we found this mass that was, angiographically occult. There was no AVM on the angio, but it was this very firm thrombosed AVM that had been treated with radiosurgery over several decades. And so this happens. And so it's important to be not aware of this so that if you're faced with this situation, you know that it can happen and you start believing it. Because when I first, this was earlier on in my practice, when I encountered this, I was like, there's no way there's an AVM here that's causing this. We should ride him through. Why put this guy through surgery? He's avoided surgery all this time. There's got to be some other explanation. So I learned something from this. We saw that the annualized hemorrhage risk of delayed hemorrhages, if you broke it down by the treatment modality, is much less common in patients who had had surgery as their treatment. Obviously, that was less than 1%. Radiosurgery, 1.2%, and then embolization only, much higher, not surprising at all. But if you had a combination of these, it was somewhere in between. And that reflects really the complexity of the AVM. If you're having multimodality treatment of an AVM, that means that AVM is more complex by its very nature. And so it's not surprising at all that you would get annualized hemorrhage risk that was a little more significant in this group. So this was the first one that really compared this delayed hemorrhage risk across different modalities. And we noted that people who had partial embolization only really should continue to pursue definitive treatment if possible. Otherwise, you'll have a delayed hemorrhage risk. And then what, of course, was the most notable point is that even angiographic obliteration of an AVM really doesn't guarantee freedom from subsequent hemorrhages. Okay. So that's it for that. I wanted a chance to have people ask questions and so forth, but I wanted to thank everybody who is involved in all these efforts. And the main person who was really responsible for putting together this database is one of my research fellows who's now joined us as a resident. That's Yang, and then various students who have come through over the years, medical students from both Hopkins and from other medical schools. There's a lot of residents who are on board with helping to write these papers, gather the data, take care of these patients, obviously. And then my colleagues listed here really in all areas, whether it's pediatric neurosurgery or vascular neurosurgery, really contribute to all this. So it's a team effort, and hopefully I've shed some light on this vexing issue to us, because if you just believe the large randomized control studies, we shouldn't be touching these patients. So, nice.
Looking for some questions? Yeah. I'm curious about your brainstem experience.
Oh yeah, I do skip through that. Yeah. Okay, so we found that there were a lot of people who had hemorrhaged, and then the ones who hemorrhaged that were treated with radiosurgery actually did fine, did okay. So it was a small cohort, so that's why I ended up skipping it. I could review it again, but so it's reasonable actually. We had obviously only one patient, I think, that was resected because it was more in the subarachnoid space, but most of them were treated with radiosurgery and they did okay.
Any other questions? Christina?
How often do you repeat angiograms on pediatric patients after you resect them?
After a resection, so we do an intra-op angio, and that's it. And I would say that depending on what their age is at the time, there's usually one that's done in a delayed fashion. We usually wait until radiation's not an issue. So in my adult patients, I try to recommend a post-operative angio at 2 years. But in kids, I would wait a little bit longer and just recommend one delayed angiogram. That's a good angiogram in a real angio suite as opposed to intra-op, several years. Yeah, so I'd probably wait until teenage years, during summer break. So
I feel guilty of something. I just operated one of our partners, Dr. Willis, used to be with us, and somebody who was 70 had multiple hemorrhages, multiple seizures, and not like a grade 3 AVM frontal. And I took it out, and he had no seizures. But if you go by your data, so sometimes I think the clinical gestalt is important because you can't just pigeonhole everything.
Exactly.
You know what I mean? And I think we've been burned both ways.
Yes.
And just to tell you how paternalistic medicine is, I think 25 years ago I operated an AVM. She was 26 years old, and they told her it was inoperable, and they did a tubal ligation on her, telling her never have children because you will die if you get pregnant. So, we took, I think, 16 hours. We took it out.
Yeah.
But she could never have kids again.
Right.
So it's kind of sad that you see that, but it's something you...
Yeah.
Chris, you had a question? Yeah.
Did you all look at data on postpartum bleeds? Because I feel like we see a lot of bleeds postpartum.
Right. So we included the postpartum period for 6 weeks. That's exactly right. So we did 40 weeks for pregnancy. We assumed 40 weeks and then 6 weeks after. Try to capture that.
And it's
exactly.
fourfold increase.
Yes.
That's important.
Yeah.
Hi.
What's your philosophy on pre-surgical embolization? When do you use it with?
Yeah. So I didn't include that in here, but we just published that. It was a shock to me, but we could not prove a benefit to preoperative embolization. If you looked at outcomes with modified Rankin,
I've always
right?
maintained
Right.
that,
Right.
so
So but that's not our practice pattern. Our practice pattern is to try to embolize every surgical case because we think it will help with the blood loss and so forth. Everybody's heard that, right? I actually think it's very helpful in identifying the feeders, because you see the onyx or you see the glue, right? So you know where you are, you know which vessel you're in, you know, so it gives you an internal map when you're in there. So we tend to try to do it, but you know, it's a comfort level of the person doing it, because you know, a lot of the, you know, if it's an eloquent area, you don't want to hurt any en passage vessels and so forth. So it's really case by case. But you know, obviously, I would say we're fairly aggressive in trying to do pre-op embolization, even though I couldn't show that it was better.
Yeah.
Yeah.
No, hi.
If you have one more question, Dr. You can go ahead.
Second question is, if some young person coming with a hemorrhage, they're neurologically more or less intact. In those cases, do you wait to resect, or you
We do.
resect?
We do. Our practice is to wait, because we think that you might as well optimize their situation, right? So even if they have a very small hemorrhage, it's probably edematous. You know, it's still the issue of when you do your angiogram pre-op, it's better to not have hemorrhage, so you really see as much as you can see, because as you know, there's always feeders you can't see on the angiogram, right? So why not optimize your situation to see as many as possible before you take someone to surgery? So we do actually let them cool off, usually 2 months. So we check a CT, make sure all the blood's gone, all the edema is resolved, there's no shift, and then repeat the angiogram, repeat the MRI, and then do surgery. Now, obviously, that's not the practice that's not common practice, I think. I think there are lots of places where you make an argument to someone neurologically intact even that there must not be a lot of edema if they're neurologically intact. You could take out the AVM there, the blood's done some of the dissection for you, but we don't follow that. And a lot of times we find that the encephalomalacia cavity helps a lot with the resection also. So then it's less traumatic when you are in there 2 months later, because you have the encephalomalacia cavity, the AVMs tend to be small, right? And it's a much simpler case, much shorter, you know, just less complicated. So that's our practice.
It's funny, you influence, Columbia is like that too, because I think when Sandra Conley was visiting, we had a young kid here with a large blood clot.
Yeah.
And I tend to go early, because I feel the dissection, it's like cavernous malformations. I
Right.
think if there's blood clot, especially in the brainstem, I would go in.
Yeah.
But I guess there's no real clear-cut answer
Right,
on that,
right.
you know.
Right.
Rimmel, you had a question?
So with aneurysm literature, they describe the rebleed rates with respect to days and weeks,
Yes.
short-term
Right.
rebleed rates
Right.
with non-treatment. I was wondering if you had insight on short-term rebleed rates. I just did. I asked this because it's pertinent to me. I had a relative in India with a temporal AVM, ruptured small hemorrhage, no mass effect, and they were going back and forth. And the neurosurgeon there had advocated for resection, and then they just wanted to get an opinion, so they were calling me, and I said, if you want to wait, it's fair to wait.
Yes.
But then they went ahead and got surgery. Patient did okay. So I just wanted to see what your insight is on that with respect
So
to
we are looking at this. This is actually, we're looking at this data right now. It's not published yet. So there is a slightly higher risk of bleed in the immediate post-hemorrhage period. It's not as dramatic as in aneurysms. So it's not enough to convince us to go early. We still think it's reasonable to go late. But there is some data that's emerging that, you know, in the first couple of days after hemorrhage, you might have another hemorrhage. Unfortunately, this data comes because it's really, just a small fraction of people where they're having multiple hemorrhages, and that drives up the numbers. So I can think of one, for instance. I have one patient who had 3 bleeds in the span of, I think, 2 weeks. That really drove up that number.
There's a very famous case of Dr. Camarada in Kansas, and he won't mind me sharing this with you. He's a chairman of Kansas, and he had just started his practice. He'd left Minnesota. He saw a young 28-year-old with an AVM, a hemorrhage, and he said, it's standard practice. I'm going to wait. You think about it. I'll come back. We'll do it in 6 weeks or 8 weeks. Headed him up. 4 weeks later, he had a fatal hemorrhage, and he died. He had a malpractice suit, and Skip Peerless, for those of you know, who worked with Drake, like the master surgeon, came as the plaintiff's expert and said this patient died, and when he was going to testify died, it was like a $3 million settlement. And that's where litigation can sometimes cloud what's science, because what he did was really medically justifiable.
Yes.
But you have an expert witness that comes and says no.
Right,
You know,
right.
So it's sort of,
Right.
Dr. Emery, yeah.
Yes, thank you. Several years ago, a neurosurgeon named Raymond Chelberg and a neurologist named Raymond Adams from Mass General Hospital published in the New England Journal a series of cases of AVMs treated for the first time with proton beam. I assume your radiotherapy means proton beam.
Actually, we're doing stereotactic radiosurgery with gamma knife and cyber knife. So that's what this series represents.
Have you been disappointed or felt that proton beam, with its all the hype about the drag peak and the focality of the energy, have you been a little disappointed in the benefits of that?
I would say I have not encountered enough patients to formulate a strong opinion yet.
And one more question on that. The poor response to embolization, that brings to mind something that's you haven't quite touched on enough. Maybe it's the pathology. These things don't have the normal three walls of normal vessels. And with the emboli, you may be plugging off the smaller abnormal vessels, but it doesn't protect you from the larger diameter vessels that still have the defective walls. That might be one explanation for the recurrent hemorrhage being so high in emboli compared to others.
Right. No, definitely. I think there's no question that embolization, these are obviously super selective injections, but the access is via the large feeders, and so you get incomplete penetration of the nidus, so that even though angiographically it looks obliterated after embolization, and you know that in Europe this is very commonly touted as the definitive treatment, only getting embolization, that's it, and they point to the angiogram and say it's cured. They view embolization in a much different way than people here do, I think, and I think the jury's out still. And it's got to be the small vessels that don't have the embolization in them, material in them. When do you manifest because this disease has such a long natural history. When do you manifest that delayed hemorrhage is the key.
I was wondering what your practices for this ruptured AVMs are inoperable, or that you want to wait to do surgery, but you can actually identify the source of the bleed, either a large intranidal aneurysm or a hyperflow aneurysm. You usually just send them to targeted embolization, get rid of the aneurysm, stop there. And
Exactly.
do you count those as embolization only cases, or
No.
They don't count.
They don't count as embolization because usually something else happens. We do radiosurgery because a lot of even obviously the ones that rupture, they're a really separate category, right? Like you're pushed. It's I did a lot of this based on trying to answer the question for people who come in without a rupture. What's their risk over their lifetime? So when you have a ruptured situation, I think it's you have a reason, you have an indication to treat. So we tend.
We have several cases that are inoperable.
Yes.
On radiosurgery, no surgery.
Yeah.
You can actually kind of see the nidal aneurysm.
Yeah.
So we go in,
Yeah.
take care of that, and stop. That's all
Right.
you can offer.
Yeah.
And when we talk about those embolization only cases, I think we're talking about nidal embolization. So you're actually going block a part of the AVM, and that's when you run into problems.
Right.
And have high risk of bleeding, nothing else.
Right. No, this is very humbling because there's all these people with very large high flow AVMs, right, where there's almost like a fistulous compartment to it, and you can see that they're having all these venous hypertension issues or steal issues, and they're very symptomatic. Have a lot of neurologic deficits, but there's nothing you can do. And we have tried on various occasions to just try to interrupt the fistula with partial embolization. We don't get good results. So it's very hard to counsel these people. I've done it multiple ways. I remember I can think of one patient that I said, okay, we'll try embolization, we'll try radiosurgery. Obviously neither worked. And a lot of my, I felt like the most important thing was to prepare her for progressive neurologic deficits. And so really we sent her to rehab. We tried to get her to, sort of prepare for being dependent, actually. Because I saw that coming in, years down the road that she would need help. She was not, we applied for disability for her, just like really trying to have her cope as best as possible because it's a chronic illness that we were not going to do anything for. And I have another one percolating right now who's like that, who, formerly an accountant, very high functioning, but he's got this massive hemispheric AVM that we can't do anything for. And because of my experience with the previous lady, I'm counseling them not to do any intervention because I don't think we're going to help.
So grade 4 and grade 5, we were doing graded surgery. So we did 2 plans. And our results were very disappointing.
Yes.
So how are your, because I know, Lunsford and all say, oh, 80% AVM's gone.
Right.
And we were just very disillusioned with that. So what
I-
has your experience been on that?
Disillusion is a good word. We have also very poor results. The obliteration rate is like in the 30s. It's terrible obliteration rates. And we're seeing, there's delayed hemorrhages. So
It's like
not,
trigeminal neuralgia.
Yeah.
You talk to them, oh, gamma knife 90% gamma. And I'm like, this is not what we see.
Right, it's not what we see either.
Just for the med schools,
Yeah,
I have students, I think this is one of the hardest decisions we make in neurosurgery.
Yeah.
Whether we should operate, not operate, how do you counsel the patients? And it's like the sword of Damocles hanging on your head. So we had a patient who's 58 years old that I gamma knifed 2-stage 28 years ago. He was 18 when he was diagnosed with seizures. And we did the 2-stage gamma knife, and he did well for like a bad seizure. Then he had a hemorrhage and dysphasic. We took out everything. And he's cured. And it's an amazing thing to tell somebody that after living for like 30 years with this bomb in your brain, it's gone. And it
Yes.
takes a big toll. I agree with you. It's one of the hardest decisions in neurosurgery.
Yeah.
Because first you want to do no harm. You
Right,
don't want to put
right.
them through all this, like a great looking angiogram,
Yeah.
patient's trashed.
Yeah, exactly.
So,
Yeah, and there's so many iterations, right? Every patient is so different. There's no two that are the same. There's so many different variations of how you can handle them. And so it's such a disservice when, what is being propagated out there in the medical community is that these are not lesions that deserve intervention. It's really a problem. And so I just think we have to keep drilling down in a more granular level, what are the specific risks in their particular situation. This is my attempt at, patient-specific and, patient-centered care, trying to individualize medicine.
well, thank you so much.
Any
Your
other
little
questions?
plaque
Oh,
for
wow.
your visit with us. Thank you so much.
Thank you.